All right, I think it is now 6 o'clock, so we'll go ahead and get started. I'll start by introducing myself and then talking a little bit about what we do at the Motherhood Center for those of you who are not familiar with us. And then throughout the presentation, you can ask any questions that you'd like in the Q&A chat, and then I'll probably get to them at the end of the presentation. My name is Dr. Stephanie Simon. I am a therapist at the Motherhood Center, mostly in the outpatient program, and run some groups in our day program. And I will explain what those two mean. So a little bit more about my background. I have done some work with specifically moms of preterm infants hospitalized in the NICU. This was during my graduate school training and my dissertation. Ran a group treatment for moms with specifically showing PTSD symptoms following preterm delivery and a NICU hospitalization for their babies. So that's kind of what I bring to today's presentation. And also I've been working with women with PMADs at the Motherhood Center. And what a PMAD is a perinatal mood and anxiety disorder. It's the new term for what you might know as postpartum depression. Kind of encompasses more presentations and symptoms. And what we do at the Motherhood Center is we provide support and clinical care to new and expecting moms experiencing a PMAD. And we do this through several ways, one being support groups. So we have a PMAD support group, we have a pregnancy support group, we have a pregnancy loss support group. We have having another child after a PMAD, so having like a second, third, fourth child after already experiencing a PMAD. Those are our support groups that you can find on our website. We also provide one-on-one outpatient therapy, talk therapy, and medication management. And then we have our day program, which is really what makes us special. This is for women who are needing a little bit more care than outpatient. It runs 5 days a week and combines one-on-one therapy, medication management, and a lot of group therapy to get moms better quicker. And so with that, I will go ahead and proceed. Okay, so today we will be talking about the experience of NICU parents. So the goals for you guys, what I'm hoping you get out of today is gaining a general understanding of the challenges of a preterm delivery and or NICU hospitalization on parents, and to learn different ways to work with NICU parents and to support them. This is a provider seminar that's just not just for therapists. I am a therapist, but I know that there can be nurses here, there can be doctors, so I'm going to try to tailor it a little bit to sort of the general provider population. Okay, and things to be aware of. Sometimes I'll use the word mother, that's just because that's the majority of the people I work with. Mostly I'm using parents, but if you do see the word mother, that will actually mean that the research I'm citing or the work that is referenced is with specifically mothers. And my NICU experience has also been specifically with preterm infants. So I'll include info on preterm delivery, but most of what we talk about can actually be applied to parents of full-term infants hospitalized in the NICU for reasons other than prematurity. And I will include a little bit more focus on PTSD and trauma as it's pretty common when you do deliver preterm that it can be quite a traumatic and sudden experience. Okay, so the outline, I'm going to talk about preterm birth, the NICU infant, effects of preterm birth or NICU hospitalization on parents, and then the interventions. All right, so start by talking about infant mental health. So the infant mental health is basically the developing capacity of infants to form close and secure relationships, experience and manage and express a full range of emotions, and really explore the environment and learn from it, and learn from caregivers as well. And with NICU and infant mental health, so the psychological tasks of infancy are handling sensory input, getting attached to an adult, learning to handle big feelings, communicating and getting your needs met, and really adapting to a changing world. And how this happens is through co-regulation. So warm and responsive interactions that provide the support, coaching, and modeling that children need to understand, express, and modulate their thoughts, feelings, and behaviors. However, the NICU environment can be pretty dysregulating. There's babies hooked up to machines that are beeping or ringing. There's a level of uncertainty about what might happen next. It's a medical and a hospital environment, and that can be quite dysregulating and make it hard for infants to sort of engage in these important tasks of infancy. And I will say, as an addition, COVID makes it even a little bit more dysregulating and difficult, as there are more restrictions on parents in the NICU. So I'm not sure about every NICU in New York where I am, but I know most will only allow one parent into the NICU at a time. So there's no bonding with the family unit. It's really between one parent and the baby. So you don't get that immediate family bonding time. And then you have to wear a mask, so that actually can limit sort of the emotional attunement. So preterm birth is an unresolved issue, both in, surprisingly, developed and developing countries. The first neonatal intensive care unit in the US was established in 1960, and basically, created technologies to save preterm infants. And so but despite the drop in mortality rates, NICU admissions have actually risen dramatically over the last several years. And that's for a range of possibilities. But 11% of all live births were preterm in 2020, so quite a bit. Okay. And so these are overall the sort of general challenges for NICU parents. Separation from baby is the most impactful for many parents. So some cannot hold their babies or even touch them in the beginning, which is quite difficult when there's an expectation for skin to skin kangaroo care. They leave the hospital without their baby, which can feel traumatic and quite surreal. Many parents have grief about the timing of the birth or how it unfolded. And some infants may be dealing with a medical diagnosis or medical diagnoses, and which can be hard to sort of accept and cope with, particularly when you're feeling not great about what just happened in terms of delivery. And it's sort of the loss of what they expected. So hopes and dreams of having a healthy baby who comes home right away. There's also stress of interacting with medical professionals continuously, the equipment and the general sterile hospital setting, and also logistical issues can also contribute to stress, such as additional children at home or having to take a leave from work for an extended period, which often some families can't do. But NICU hospitalization really can range from days to weeks to months. So this is a similar slide, but some more specific sources of stress in the NICU. So again, prior to birth, parents develop expectations around how the pregnancy and delivery of a baby should be. which often makes the onset of early labor or a delivery of a baby that needs to be hospitalized, and preterm birth sudden and unexpected. And parents often become alarmed by the sense of urgency in the delivery room evoked by hospital staff, as well as the sudden transfer of their baby to the NICU. So it's possible that there is no opportunity for skin to skin and that immediate bonding that parents often expect and desire. And NICU infants' health and stability may also be unpredictable, which leaves parents concerned, worried about their child's survival. NICU stay can mean many different long-term effects on babies' health and well-being. And a principal source of stress associated with PTSD symptoms in parents of NICU infants is the alteration in the expected parental role. And what I mean by that is nurses and doctors sort of become, in a way, primary caregivers just because they're there with baby 24/7, whereas parent has to leave at some point if there is no bed in the NICU. And sometimes parents aren't able to feed baby right away. They might not have permission yet to hold or to move baby. So it's really not the same, the parental expectations. And also lastly, the appearance and behaviors and gestures of a preterm baby and the NICU environment can be stressful in nature to mothers, especially the infant's erratic breathing, atypical color, and small size, and also the medical equipment and tubes used to support the baby. So my next slide is going to have a photo of a NICU baby. So I just want to give a forewarning because it can possibly be triggering to some. So if you'd like, you can kind of just look away. I'll let you know when I go to the slide after that. I just want to, for some people who are interested and don't know what it looks like to see a preterm baby in the NICU, I just kind of want to give a visual for that for some. So I will move my slide now. And as you can see, baby's really small. Their skin looks sort of like translucent. There's a lot of tubes and wiring, and it's not what's expected necessarily. All right, I'm going to change slides. And so the grief and loss model is another sort of way to conceptualize the experience of some parents of preterm or NICU infants. Grief and loss model is one of the earliest and most widely accepted models used to explain and describe the psychological reactions of parents to the birth of a medically ill infant, and now it's sort of been adopted as the way to describe the psychological reaction of preterm infants or infants born in the NICU or hospitalized in the NICU. So parents, need to change their hopes and expectations for their children due to uncertainty around the preterm infant's medical status and developmental trajectory. Parents may have to mourn the loss of their anticipated birth, of certain parenting experiences, and often the vision of a healthy, medically stable infant, while also at the same time developing an attachment to baby. So there's a lot of tasks while often feeling distress and this sort of sense of grief. Parents may experience emotions associated with grief and loss after the birth of their preterm infant, and this can include anger, sadness, and shock. These feelings can have negative effects on the parent-infant relationship, particularly if complex feelings and emotions are left unprocessed or unresolved. That often can lead to postpartum depression or anxiety, or again, what we call a PMAD. So in continuation, NICU parents are at greater risk for PMADs. I think it's about 10 to 15% of new parents or new moms develop a PMAD. It's much higher in NICU moms. So for NICU families, the rate of a PMAD is anywhere from 28 to 70. I know that's a big range, but certainly higher than the 10 to 15 we often see in the general population. Partners can also experience a mood disorder. And again, what perinatal, in case people came on late, a PMAD is perinatal mood and anxiety disorder. But it doesn't often, like semantically, it doesn't really capture PTSD, mood and anxiety. So, but that is something, PTSD the rates are definitely elevated in NICU parents, but PTSD is often overlooked in this population. You know, we talk a lot about postpartum depression, postpartum anxiety, and PTSD is certainly something that we often see in parents of preterm infants. So post-traumatic stress, PTSD has recently been identified as a model for describing and explaining the psychological reactions of parents to their experience in the NICU. Not only is there a higher risk of developing trauma symptoms in parents of preterm infants, but also, as you know, you might know, parental PTSD has been associated with a reduced ability to cope with stressors in the NICU, distorted maternal perceptions of their infant, which I'll talk more about, increased feelings of detachment and separation from infants, and then negative influences on parenting. And so viewing the NICU experience as a trauma is helpful in understanding and interpreting parental reactions and establishing preventative and treatment interventions for this population. So I'm not going to go through this too much. This is just the difference between acute stress disorder and post-traumatic stress disorder. The main difference just being the duration and the onset of symptoms. So acute stress disorder is sort of the immediate fight or flight post-traumatic reaction that starts from 3 days after the trauma exposure up until a month following trauma exposure. And then PTSD is basically the more of like the long-term post-traumatic reaction. So over a month, if those symptoms persist, which often they don't, but if they do following that first month after trauma exposure, it would be in the PTSD realm. And you know, these symptoms, I'm sure most of you might know, and you can always look this up in the DSM, intrusion symptoms, so memories, flashbacks, nightmares, avoidance of internal, so thoughts, emotions, and external context, so things that remind them of the trauma, mood changes, so beliefs, shift in mood, diminished interest in activities, and then the arousal and reactivity, so irritability, angry outbursts, reckless or self-destructive behaviors, sleep problems, concentration difficulties. And this can be sort of the delivery experience if it was preterm, but also the NICU experience. Okay, so this is an important one. I think, you know, we've done some research. I had a team that I worked with my dissertation on, and we sort of studied the differences also between how moms and dads or partners cope with a NICU hospitalization, or specifically preterm birth. And it's quite different. So fathers, and this is a gendered finding, fathers had a delayed reaction in terms of their trauma response. So by 4 months, maternal trauma symptoms actually had diminished, but father symptoms had increased, and in fact exceeded those of the mothers. It appears that fathers tend to keep their emotional reactions in check for the first few months, perhaps, and this is again a hypothesis, but perhaps to allow full support to be given to the mothers. However, by 4 months, when mothers are recovering, the fathers go through a very difficult period. And awareness of this phenomenon is really essential to ensure that fathers' needs are not overlooked or not like neglected. And incorporating father, if we are treating mom, incorporating the father into treatment and having some family sessions can be a great way to do that. Just looking through the slides, see if I missed anything. Okay. And this is sort of what I've just described, the difference at the time of assessment between moms and dads. So again, there's a little bit of a focus on PTSD here, but there are long-term effects of postpartum depression, postpartum anxiety as well. And these are can also apply a lot to both, I would say, to postpartum anxiety specifically. So parents with PTSD tend to be highly anxious and prone to overinterpret mild distress in their children as indicating possible serious illness. So they may constantly expect their child to become ill, recreating the feelings of anxiety and distress they experienced at the time of their child's birth. They may repeatedly bring their children to the doctor, often unnecessarily, and in doing so, foster a pattern in which their child manifests physical symptoms as a way to express emotion. So I kind of broke this all up into like behavior management, maternal overprotection. It could also be paternal overprotection, just parent overprotection, and health concerns. So what we see here is difficulties with discipline, limit setting, and this goes beyond the NICU stay. This is parenting long-term effects. So, and disciplining may be difficult because it may actually be associated with flashbacks from the NICU. We might see continued concerns past, well into the child being a toddler, health and physical concerns, fears of violence, and then, and we're going to talk more about this in a bit, and worries about speech, developmental delays. There might be an increase in seeking medical advice, medical appointments, and particular difficulties during episodes of poor health, like a cold would be maybe exaggerated into worries of baby dying. Okay, so vulnerable child syndrome. So parents may also develop, this is something to sort of look out for, to plant seeds on, and I'll talk more about this in a bit. Parents may also develop symptoms of what has been termed vulnerable child syndrome. So I don't know about all of you, but to me, that's like a scary name. It just seems worse than maybe it is, or syndrome has sort of like a negative connotation. Syndrome is just a group of symptoms which consistently occur together and like fall together. And in this phenomenon, parents with a history of having a medically fragile infant become overprotective, limiting their child's independence because they want to make up for the loss they experienced or their child's trauma of being born preterm, being hospitalized. And this may essentially result in children becoming oppositional and defiant as they get older. So let's see. And there are some examples that I wrote out here. A lot of it is you can see this in the high frequency of healthcare use. So anytime baby has a symptom of any sort, we're calling up the doctor, we're finding out what it is, and there might be sort of a catastrophizing. And this is more likely to occur in educated mothers and those with less marital support. And I'll talk more about this. Okay. And I see that there is a question, but I'm going to hold off until the end, mainly because I might answer it, but also because I'm terrified of clicking the questions and then losing everything here. I'm not so technologically savvy. Okay, so more on vulnerable child syndrome. So the last slide kind of described like what it is. This slide is showing really how it manifests specifically. And there's an interactive quality, like anything relational, right? So the parent is anxious, child becomes anxious, irritable, disobedient. So first and foremost, it comes with this difficulty with separating. So rarely getting babysitters, rarely having other people watch baby or watch the child. I should not just say baby because these are long-term effects. Sleep problems can manifest. Parents might check on the child frequently, particularly at night, make sure they're breathing, make sure they're okay, they're in their room. And then we have infantilization. And this is when a child is being treated in a manner appropriate only for a younger child. In other words, treating one who has a mental capacity that's greater than that of a child, as though they are a child. So, you know, treating a 6-year-old as though they're a 2-year-old. And this may come out in the difficulty setting limits, saying no, holding boundaries, which are very important for children. They need structure. They need to know what's allowed, what's permitted, what's not, to feel protected and safe. And this can lead to disobedience, irritability, feeding problems. And then there's also bodily over-concern. So there's like a heightened anxiety around, if there's a heightened anxiety around child's health, the child might start to develop like somatic symptoms and complaints, and that actually might cause them to not attend school. So this can lead to one thing to the next, and also has been associated with school underachievement. Okay, so I talked a lot just now about sort of what we see in NICU parents, specifically NICU parents who delivered preterm. That's like the population that I have most closely worked with. And the long-term effects of those psychological and emotional challenges. And now I'm going to focus more on how do we help this population? What can we do? So first and foremost, and this is sort of a list that I'll go through, screening. So there are NICU parents often miss the traditional screening opportunities. They're more likely to miss follow-up OB appointments, just given how many appointments baby ends up needing, especially if they're born preterm. So they're often missed with that routine screening. Some NICUs are instituting screenings for moms with the EPDS and other screening tools, but this is not nearly as widespread as it should be. Traditionally, providers have noted they don't screen due to lack of treatment options. So if they screen, they'll have to do something, refer the parent somewhere, and there's not that many treatment options. While this is shifting, screening does still lag behind. Additionally, parents tend to put themselves last when a child is in the NICU. There are so many time constraints, work, family obligations, and wanting to be in the NICU as much as possible. So we often miss the distress that NICU parents might be experiencing and presenting with. One thing that has been shown to help in terms of NICU parents seeking therapy or taking care of themselves is actually the encouragement of the nursing staff. So this is whom families interact with most closely during their time in the NICU. So it's really important, and what the Motherhood Center is really trying to do, and part of our work here is outreach, education, because nurses and other providers are really important in getting patients into mental health care. So if we can educate nurses about what to expect, what to see, how to screen, how to refer, what resources are available, that would be a great first step. I included some screening measures. There's a specific NICU screening measure that is really, it's specific in that it kind of, it captures the specific stressors that are arising from the physical and psychosocial environment of the NICU. So like what is triggering these parents each day? And that's the Parent Stressor Scale Neonatal Intensive Care Unit. It's kind of a long name. But then we have the EPDS, the PBQ, Davidson Trauma Scale, the BDI, so a wide range. Any questions about that, I can answer at the end. Okay, so infant redefinition is like a fancy term for what I kind of seem to be is like a whole bunch of these different, if we look at this list, it's basically just like fostering the attachment and a secure attachment, but specific to sort of like NICU hospitalization, preterm infants. So if this is the only thing that you recall from this presentation, that is great. This is really the essential part in facilitating the parent-infant bond. So expectations for parenting and attachment bonding change, like I mentioned before, upon preterm delivery and NICU hospitalization. So parents really need to adjust. And the way that we can help them do this is through this process of infant redefinition, which I'll explain. We're really, with infant redefinition, enhancing confidence in parenting skills, parenting of a NICU baby, reducing the perceptions of infant vulnerability, which, if we are doing that, planting seeds early on, parents are less likely to develop vulnerable child syndrome, right? And again, reducing the potential for vulnerable child syndrome. So just as a very quick tip, like one way you can start, and I'm going to talk a lot about different ways that we can do this, but one way just that you can start the conversation with a NICU parent as a nurse, as a social worker, as a therapist, is asking, what's your baby's name? And how did you choose their name? And does that name have meaning for you? Who do they remind you of? Do they look like anyone in your family? This immediately starts to define the infant as a person, as a baby, rather than an object that's tied up to all these machines that's requiring medical attention and persistent checkups and medical care. Another way we can incorporate infant redefinition is utilizing a baby diary, which I'm going to include like sheets and handouts from and sort of explain them, which it's filled with different concepts, different activities. This can be done in writing with the parent or verbally, just depending on your style and the parent's style. And I'll go through all of that now. Okay, so I'm hoping you all can see this. If for any reason the font is not big enough, Shannon, just let me know. So we see babies all over neighborhoods, in ads, on billboards, at the sides of buses. We see them in person in strollers on the sidewalk. We know what to expect in terms of what full-term babies look like, right? However, when's the last time, besides the picture I just showed you, that you saw a preterm baby? So not being familiar, most people don't know what a preterm baby looks like and what they feel like and what movements they make and how they behave. And this can really result in anxiety for parents of NICU babies. They worry about what's normal, what's not normal, what should I expect, what's not, what shouldn't I expect? And so what we do, what we can do is to share with parents what to notice at various stages and discuss their reactions to this. So we go through sort of common features of preterm babies. It's quite simple, but goes so far because because moms then, or parents, have knowledge and understanding of what their baby is experiencing, and that it's quite normal. So we're teaching parents about infant characteristics and behavioral states and empowering them through this knowledge and awareness. So I will go through this list verbally. I don't often use handouts in individual work, but you know, you can actually provide this to parent and go through it with them, whatever your style is, but really paying attention to how they are small, they're thin, they have tubes and wires attached to them, and their skin might be blotchy, might be a bit translucent, and they sleep a lot. And preterm babies sleep a lot because they're still developing. Like, they're developing as though they were still in the womb, right? And when awake, they might look groggy and out of it. Their muscles might appear floppy. And because of this, they have like very jerky movements, which is normal. That's a normal thing that preterm babies do. They have these jerky movements. They might not always respond to talking or stroking because they're generally less active. They're less alert and they're less responsive. They sleep a lot. And their cries might be more weak, inaudible. And it's really important for NICU parents to know the monitor doesn't always mean immediate danger. So when they hear the sounds of the alarm, that can be for many, many reasons, and it's just to get the attention of the nurse. So not always necessary to worry about the alarm or the monitor. Another really important part of sort of educating parents of NICU babies, preterm babies, is multisensory stimulation. So nurses and doctors are with babies all the time in the NICU, and this can lead parents to feel helpless, unsure, like, where is my role? What am I supposed to be doing? And multisensory stimulation is what parents can do for and with their babies right now. And I will tell NICU parents that multisensory stimulation is its own form of medicine. And that sort of empowers NICU parents. Like, these are things that they can do for their baby. This is the medicine they can provide. I will say everything needs to be run by the doctors and the nurses first to find out if baby is ready for these things. But we're basically educating parents about how to be sensitive to their infant's cues and to use themselves as a way to bond, connect, and care for baby. So, and we break it down by the senses. So auditory, touch, visual, motion. So and it's split up, as you can see on this sheet, as when you're with baby, these are the things that you can do. You can do skin to skin if baby is ready and nurse approves. You can provide containing touch. What this means is sort of hand containment is like a gentle but secure placing of hands on the infant's head and body. It recreates the warmth and containment that infants crave. It's sort of like hand swaddling. We can get up close to baby and look at baby. We can hold eye contact while feeding if we're able to feed. And wrapping baby in a blanket, gently rocking baby back and forth, holding baby swaddled, talking, humming, singing. Baby will eventually begin to recognize your voice as a parent. And then in between visits, which is often the hardest part for parents, is leaving if they are coming to visit. And what we've actually, there is some research on what we call scented hearts. So you put like this little, and some NICUs provide it, but you put like a little piece of fabric in, moms put it in their bra throughout the day, whether they're at work or in the NICU. And then when they leave the NICU, they leave that sort of felt heart in with baby, and it has mom's scent on it. And it actually, research, it's incredible, has shown that leaving a scented heart actually can speed up, can cut the NICU hospitalization by a bit. I don't know the exact numbers. I just know that it really does make a difference. speeding up development. And then we can carry a picture of baby with us. We can leave a picture of us with baby, share observations with people we love, with nurses and doctors about what we've seen in baby, what we're learning about baby, and asking questions. I think that can be a tough one for parents, is like, am I bothering the doctors? Is my presence here unwanted? But really encouraging parents to ask questions. How is baby doing? Are there changes that you're noticing? What's their health like? And to feel really more empowered. But what I will say is, sort of a takeaway, is multisensory stimulation 3 times a day for 10 minutes can help promote faster growth and development for NICU babies. And that sort of nugget for parents can be extremely powerful. Okay, so again, there can be a sense of hopelessness in the NICU around what role you play as the parent compared to provider, nurses, doctors, social workers. They're doing a lot there. And you can ask verbally, what did you do with baby today? What did you enjoy doing? What was the most challenging part of being with baby? What do you want to do with or for baby next time you visit? You can even track these activities with this sort of handout, or just pull from it. But having parents fill this out day to day can feel like they're doing something for baby. Like they're not just sitting there, that the nurses and doctors and social workers aren't doing everything, that they have the capability of parenting, even if baby is in the NICU. So we're really encouraging parents to observe changes in their baby, part of infant redefinition, redefining the parenting experience by helping them recognize changes, and increasing their comfort and confidence, and by providing this sort of visiting log where they can track what do they do with baby each day. Okay. Similarly, so often with a full-term baby or an uncomplicated delivery, we bring baby home and immediately start a baby book. It's like something that we know from pregnancy that we're going to do. We have a baby book ready, and we record baby's trajectory and development on that. When something so sudden, unexpected, and scary happens, like a NICU hospitalization, it's really easy to forget the details, like a baby book. And it's easy to forget, with all these stressors in the NICU, the importance of recording milestones. So encouraging parents of NICU babies to record and reflect on everything that they've accomplished as a new parent, and everything that baby is accomplishing in their growth. And again, up to your style, you can provide these, you can sort of go through them verbally, and really empowering parent to recognize, this is all that I did for baby, and this is all the ways that baby is growing, developing, noticing me, getting to know me as the parent, etc. So I'll give you a second to just look through these. Okay. These are very similar. We're basically kind of writing out baby observations and mothers or parents' experiences. So this really facilitates parents getting to know their baby. Difficulty bonding, like I had mentioned earlier, is a symptom of a PMAD. So what can happen with impaired bonding is parent sees baby as an object, or can see baby as sort of an object, and their parent's role becomes defined by tasks and things that they need to do for this sort of object. And what we want to try to do is facilitate baby becoming a subject, a human with preferences and a personality. And one way we can do this is noticing baby's cues, learning their triggers, and responding in different ways until we know what they like and prefer, and establishing a relationship. So there's one or two of these listed in baby observations, but there's so many. So I'll say a few, like, I know when you're calm and comfortable, when, and you have parent fill that in, verbally or in writing. Things I can do to help you feel calm and comfortable are things that seem to stress you, are some ways that you show you're stressed, some things you do to soothe or calm yourself. Things I can do to help you when you're stressed are you show me that you're interested in something by you give me cues or signals to tell me that you are ready to interact with me. These are those cues and signals. You have already changed a lot since you were born. Some of the ways you've grown or changed are so you can ask these questions in sort of an interview format, or you can have them record, or many different ways to go about this. But what you're really facilitating is how are you getting to know your baby's cues? How are you responding to them? And then what the parent's experience is beyond that one that's listed. You can ask about memories of times you really enjoyed interacting with baby. Some moments when you felt so good about being with baby, or parent felt so good about being with baby that they didn't even notice all the medical equipment and were mainly focused on connecting with baby. Something they look forward to doing for and with baby, and ways that they can imagine they'll be when they get older. And then we're asking about caregiving goals. What are things you want to do with your baby in the future? And this helps parents to anticipate future changes that they can expect in their baby, and then the bond and connection. And then I'm going to go through this quickly. This is like a letter to baby. And this can often be like nearing discharge in the NICU, like a sort of a way to reflect and look forward. So I have all these questions listed, and you can kind of like, you can ask parent to write this. You can sort of do this verbally. Again, it really depends on your own style. But really the goal being to identify what they know about their baby so far and how they've gotten to know their baby, what they've learned throughout the NICU experience, describing their relationship to baby, identifying the strengths that their baby has shown throughout the NICU. You're really trying to make redefine baby, as a subject with likes, dislikes, preferences that mom or dad can connect and bond with. And then lastly, what are your hopes and wishes for a baby's future? Okay, I'm noticing the time, so I'm going to kind of speed through this a little bit more so we have time for questions. This is an important one. It's kind of tough to do clinically because you're sort of forward thinking in a way, but you're really planting the seeds here. We talked about vulnerable child syndrome, and this is a real long-term effect. Like, this happens, and what we want to do is foster a successful parenting style for when baby is not a baby anymore, when baby is older. Again, parents with PTSD, they tend to be highly anxious, prone to over-interpreting mild distress in their children. So what we want to do is we want to really talk about that, like describe to parents that parents who fall into this pattern won't leave their baby, won't let baby do things, even if they're developmentally ready and appropriate, like tummy time, eating solids, frequently checking baby for signs of illness, difficulty setting limits. What you're basically doing is sharing, like, this is something to look out for. This is something we see in NICU parents long term, is like seeing your baby as more fragile and vulnerable than they actually are. Baby is going to grow up to be a child, and the child might not be medically unstable, but parents might continue to treat them as though they are. So something like that, and really laying out, these are the signs we see, so be mindful of them. We don't want to make parents more anxious, but it is important that they have this knowledge and awareness. And you can ask them, can you imagine falling into this pattern? And I know I ran groups with moms of preterm infants. And when we asked this in the group, I remember the moms, almost all of them, they said, not me, but I can totally see my partner falling into this pattern. And it was really interesting. So this is something that you want to share with the family system, bring in both parents and talk about this, falling into this potential pattern. And then what we want to share is explain and describe ways to avoid falling into this pattern. So these are the signs, and this is what you can do to make sure that you're developing a more successful and appropriate parenting style. So saying things like, you can hold and interact with baby and have worried feeling. Don't let the worried feelings keep you from interacting and holding baby. Doing things with your baby, even if you're nervous. Being mindful of ways baby is developing new strengths and abilities. So like seeing baby as someone who's strong and developing and not fragile and weak. Being mindful of ways you may view baby as more fragile and less competent, and really catching yourself in that. So explaining this to parents. And it's very important to share with partner, family, therapist, if and when they are feeling anxious and experiencing these issues. We want to encourage these parents to seek help if this is something that they're going through and noticing. And again, I will say, like, it is very important to set limits as a baby gets older, as a baby turns into child. Not just important for the parent, but really important for child. Gives them a sense of security and self-control when they know what to expect and there is structure in place. And if you're not able to do that, that's going to cause those problems that I mentioned before. So I'm going to go through this very quick. The NICU environment, like I said, is very dysregulating. It can cause physical fight or flight reaction, wherein there can be persistent and long-term sort of heightened physical agitation, sweating, heart rate trembling, that typical fight or flight reaction. And what we want to do with this is educate about the symptoms and how they can be expected in such a dysregulating and tough environment, and ways that they can relax. So we teach parents of NICU infants progressive muscle relaxation, deep breathing. These are just coping skills. I'm not going to go through them in great length because you might already know them. But we want to give some skills. We want parents to walk away from the NICU when they're no longer able to be there, with ways to regulate themselves. Tips to reduce stress and increase support. Again, I'm going to kind of rush through this a little bit. Telling parents it's okay to take time off. Your rest benefits baby. To take a rest from breastfeeding. That milk supply actually is better with lower stress. To talk to supportive friends and family. Eat well, exercise well, and engaging in coping skills. I'm going to go through this next one a little bit more. So if parents of preterm or NICU, general NICU infants have another child. So what we want to suggest to parents in this position is answering their kids' questions honestly and simply, making sure that they know they didn't do anything to cause the baby to be born early or to be in the hospital. And talk to them about their feelings and validate their feelings. Showing them like the characteristics of baby, with pictures, with videos, and especially because parents are often spending a lot of time in the NICU, set aside special time just for the sibling. This is special time, 10 minutes a day, with just mom, and you have an activity that you do together. Reality testing, cognitive structuring. I'm not going to go through what cognitive restructuring is because this is kind of a basic skill, but what I did want to share is the common thoughts and beliefs in NICU parents. This is something we see like across the board. My baby being preterm or being sick is my fault. I somehow caused this. And when baby leaves bedside and something bad happens, or maybe not even bad, but like the monitor goes off, let's say. I shouldn't have left bedside. This happened because I left bedside. I'm not a good parent. I'll never have a normal parenting experience. My baby's too fragile. I'll hurt my baby if I touch them. My baby looks always like they're in pain. My baby is closer, feels a better relationship with the nurses than me. I'm not the parent. My baby will forget about me when I leave bedside. My body failed me. That's a big one. My baby looks nothing like me, or my baby looks strange, and that can lead to a lot of different feelings. And what we want to do, again, cognitive restructuring, reality testing, is, it happens when the internal world and the external world may appear to be the same and this happens when the ego is under immense stress. So we're getting parents to think of all the different alternatives. Like, okay, you left bedside, or your baby was born preterm, but like, you're saying you caused this, but like, what about everything else that happened during pregnancy, et cetera, et cetera? What are all the other alternatives for why baby might have been born preterm that really might not have anything to do with you? Rational, positive self-statements. These are just kind of reminders to give parents. I'm not going to go through them too much. You can, we will send this so you can look through these. Okay, this is an important one. So challenges for NICU parents after discharge. So discharge can happen unexpectedly often. Like, we don't always know when that's going to happen. And parents may not feel emotionally prepared to bring baby home, especially without help of others. Like, when they're in the NICU, parents get help from social workers, from doctors, from nurses. And going home often means going home alone, especially if partner or family works. Challenges in bonding with baby given a new context without assistance. It can be overwhelming, particularly if a PMAD persists, because we know one of the symptoms is difficulty bonding. New mom groups or classes don't often have moms with NICU infants, so it can actually feel like a pretty isolating experience. And then babies born preterm specifically may have long-term medical issues like respiratory problems, cerebral palsy, developmental delays, eye damage, hearing challenges. And full-term NICU infants may also have ongoing medical needs and appointments. And then there are financial stressors. NICU stays can be days, weeks, months, but then there's also time off work, ongoing medical appointments that require financial, can be financially burdensome. So resources post-discharge. Treatments are available if parents are coping with PMADs, and that includes CBT, interpersonal therapy, trauma-focused therapy. Talk therapy is the first-line treatment for PMADs. Medication is also needed and useful for some parents. Often moms do not have to choose between breastfeeding and medication. Transmission rates of several medications for depression and anxiety are very low. So if this is something that is important for that particular parent, really getting them set up with someone like and we have this at the Motherhood Center, a reproductive psychiatrist that can just kind of really explain how low risk medications are. There's also support groups. We did run a support group at the Motherhood Center at one point. We might run it again, NICU parent support group. And then the social workers at the NICUs can also be really helpful in providing resources. Okay. And here I just listed some references, some of the papers and that me and my team wrote on screening, on NICU stress, and all of that. And let's get to some questions. Okay, so let's see. I'll do the earlier one. So, okay. So, Joan asked, would you say a lot of these PTSD symptoms are the same for the parents of a stillborn or a child that dies in the NICU? That I really don't know the answer to that, but I do know that the reaction of a stillborn or a child that dies in the NICU is going to be much more grief stricken. So I think the work there could potentially be post-traumatic stress disorder and work around that, because it is so traumatic, but you're going to be weaving in a lot of grief work. And we do at the Motherhood Center have pregnancy loss support groups. We don't have support groups for a child that dies in the NICU, but I know that there are support groups at Mount Sinai that target that population. Okay, and then are we going to speak about NICU babies once they're home? Yes, and everything that I talked about is also can be taken into at home. Like all the infant redefinition, that's going to continue past the NICU hospitalization. You're still working on a connection, attachment to baby, even after the NICU. And I know I've just worked with someone, or I'm still working with someone who whose baby was born preterm. She was in the NICU for about 11 weeks, and now and she didn't really want to do many sessions during the NICU stay because there was so much going on. So we only had a few, and we paused treatment, and now we're really doing the infant redefinition work. So this doesn't need to be sort of committed solely to the NICU environment and context. You're working on attachment as much as you can, even at home. Let me know if there's a more specific question there and if I answered that. Let's see. And then are going to talk to setting limits in the NICU for parents in regard to how much time they spend there. That's a great question. I mean, this like varies, I think, from parent to parent and really depends on context, contextual factors. So if parents are strapped financially and they need to return to work, they might not be there as much, and they might not be able to be there as much. And then there are parents that are there, want to be there every single second. And that was, someone I've worked with that's come up. And what you can just, what I think is important to understand with a parent like that is why. So what is the reasoning that they feel they need to be there every moment that they possibly can be? Because that can be driven by different feelings. That can be anxiety that if they're not there, the baby is going to somehow experience something like a near-death experience. That could be more because if I'm not there, I feel guilty. So it can be anxiety, it can be guilt, it can be avoidance of being alone at home. So we want to understand and explore the sort of foundation of that. And if you believe as the provider that being there, that they need to be setting limits, like you'll know the patient well, hopefully. And if you feel the need that they need to set limits, with how much time they're being there, particularly if partner is not able to be there because of COVID, there only can be one person there, and they're not giving partner enough time, I think that's a very important part of the treatment and the work is to set limits. How much time is okay for you? How much of this is being driven by the guilt, the anxiety, the trauma, and all of that? And what's reasonable for you? What's realistic and reasonable? Great question. Oh gosh, I mean, this is a great question too. How do you help the parents share with other mothers when other mothers have full-term babies and have such different experiences? I would say finding a NICU support group. I mean, they're not as plentiful, but they do exist. And then there's some NICUs that actually have peer, like mentor support. So like peer support as in like NICU grads is what we call them. Their parents like will keep in contact with the social worker and say, like, if there's a mother that's struggling, have them reach out to me. So connecting, connecting to other mothers with full-term babies who have such different experience, educating them. So this is what happened to me, and this is how I'm feeling about it. If they're comfortable, if they're willing, maybe even if they're not comfortable, but if they're willing, and to describe what that experience was like. And, but it is really hard because they're two different, very different experiences. But I always encourage parents to, if they are going to share their experience and describe and explain their reactions to it to parents who might not fully understand because they haven't experienced it themselves, to start with someone that they very much trust. So not to start with someone telling someone who they just met last week at a coffee shop, but to start by telling someone like a really trusted sibling or a really trusted dear friend that they've known for a very long time, and to build up to the more difficult people to communicate with. Okay. Randy asked, do you find a difference between PTSD symptoms for parents who are prepared during pregnancy that baby would be going to the NICU? I actually don't know the answer to that. I have no idea. But I would imagine, just my hypothesis would be, if they're prepared, like I know that baby will be in the NICU during pregnancy, it's less of a sudden, unexpected experience. So I would imagine that maybe the symptoms would differ. But I don't have the exact answer for you. Any more questions? Okay, so I want to thank everyone for joining. It's a really important topic that does not always get enough airtime. And we really appreciate you signing on, getting to know the Motherhood Center a little bit more. And we have a bunch of other seminars coming up. We have a monthly provider seminar. So every month we have someone new talking. Next month in September, I think we have two. One of them is on attachment and led by my colleague, which will be great. And you'll get an email of different offerings that we have and also a PDF of these slides. And if you have any more questions, feel free to shoot me an email. I did not write my email, but it is very easy to remember. It's S as in Stephanie, Simon, so SSIMON @themotherhoodcenter.com. Thank you all so much.